morning, everybody. I'm William Slattery from the House Institute Foundation. I'm pleased to welcome you to our seminar today called Early MRI Protocols to Understand Pathophysiology of Sensorineural Hearing Loss. Our seminar today will cover several key areas. We'll begin with the seminar objectives and then provide you an overview of sudden sensorineural hearing loss in the Hearing Science Accelerator Initiative. From there, we'll dive into central research questions, followed by an open discussion of future innovations in imaging technique and clinical research. We're honored today to have 5 esteemed clinicians and researchers, each of whom will share insight related to imaging protocols and their clinical potential. The concept with this seminar was to identify current imaging modalities that may be applied to sudden sensorineural hearing loss. Before I begin, I do want to give a shout out to our Hearing Science Accelerator team, Shims Najjar, Jane Cabison, and Madeline Poe, whose efforts in coordinating the speakers and putting the seminar together has been instrumental in making this event possible. So let's go ahead and get started. So next slide. First, I'd like to give you a little bit of an overview, as I mentioned, of the agenda. We'll start with talking about, I just covered the goals. I want to talk a little bit about sudden sensorineural hearing loss, just so we're all on the same page. Give you an overview of the Hearing Science Accelerator. I believe everyone who's on this seminar has received a copy of our publication that we did last year. We'll give you a little bit more insight into that. Talk about the specific research questions we want to talk about today. And then talk about the goals and objectives that we want to cover. So I think most of us are pretty much aware of sudden sensorineural hearing loss. It's rapid onset, usually in one ear. And in this case, we're talking about cases for which we do not know what the cause is. Sudden hearing loss, of course, can be conductive, sensorineural, or mixed. In this case, though, we're really looking at sensorineural hearing loss in nature. The clinical guidelines that have been published talks about it occurring within a 72-hour window, but the reality is most of the time it occurs within an instant. And I'll just use myself as an example. I had a sudden hearing loss. It was 1:45 in the afternoon, and I knew exactly when it happened, and it was complete within seconds. The definition audiometrically is defined as hearing greater than 30 decibels, affecting at least 30 consecutive frequencies. The Hearing Science Accelerator, next slide, was put together in an effort to address issues within hearing science for which there's been a lack of new treatment options. So as an example, steroids for sudden sensorineural hearing loss were first introduced back in the 40s. Since that time, we still talk about, well, what caused it? Is it, what's the etiology? Is it vascular? Is it viral? These different theories abound, but for the most part, we still are no closer to understanding this disease than when I started clinical practice 30 years ago, and even before that time. So the idea is to try to foster collaboration and change the approach with hearing research from iterative to innovative, and that's our goal with the Hearing Science Accelerator. We accomplished this process, next slide, in 3 ways. That is that we have a 3-part process with the Hearing Science Accelerator process. The first part is disease prioritization. The idea with this is we put together a steering committee, have several conference calls where we identify participants to help us with this. We do a significant literature review and a systematic review of the literature in the areas that we're talking about. For sudden sensorineural hearing loss, we've actually identified 3 areas, which was etiology, diagnosis, and treatment. We created subcommittees to actually develop some of these topics. The thing that makes us a little innovative is that we then have a disease workshop where we bring together people from within the hearing science field, but then also individuals from outside the hearing science field. And at this workshop, we had about 20 people within hearing science and 20 outside. And then we put together a manuscript, and that's the manuscript that's been published. The next part, which is also the hardest part, is the disease initiation, because it doesn't do us any good to have research questions if we can't address those research questions in some meaningful way. Just to walk away from a conference, which I've done many times, and we say, hey, these are the things we should address. Unfortunately, unless we have purposeful action, many times these research ideas are then discussed at the next meeting on that topic, and we really don't move things forward. So it's part of the idea with this is this disease initiative, and this is part of the process and why we put this seminar together today. The research, with the workshop, we came up with 8 research questions. These research questions were actually to help us identify what is the questions and how can we potentially address these questions going forward. And so the 2 questions we're really focusing on today, next slide, are the questions that have to do with MRI scan. And one of the questions that came up is, can MRI predict either response to treatment? Is acute MRI scan safe for injured ear? It came up, and some people said, well, you know, the reason you do an MRI scan is to rule out retrocochlear pathology, so there's no urgency in doing this. But then the question is, could acute MRI scanning help us understand the pathophysiology of acute ear disease? And so several subtopics under this: is MRI noise safe in the setting of acute hearing loss? Is it possible to get a quieter inner ear hearing protocol? Can the MRI scan help us determine the etiology? Are there things that we could do if we did things early on, did maybe serial MRI scans? Would that help? We do know that sometimes, you know, you can see bleeding in the labyrinth, but again, most of the time we don't get acute MRI scans within 24 or 48 hours of the onset of the disease. So the question is, would that be helpful in us understanding either the etiology or else help us with prognosis? The other question that comes up is, can early MRI scan demonstrate what the role of high drops are with the sudden hearing loss? Then the next question we talked about was, can we use either functional or other imaging studies to identify the site of lesion, better predict prognosis, or have a different treatment protocol? And the concept with all of this is to look at how can we all collaborate together, maybe have multi-center studies where people are doing these MRI protocols or different protocols that we would be doing in different centers to help us understand a little bit more about sudden hearing loss. So again, would earlier testing help us? Would it help us understand the natural history or prognosis? Let's see, this question 3 also talks about audiometric responses that we can potentially correlate with this. And then coming up with a standard testing protocol, which is outside this seminar necessarily. But again, looking at how does all these different pieces fit together when we start to try to understand the pathophysiology, diagnosis, and our prognosis to treatment. So with that, the goal of this seminar then is to have some baseline presentations. So again, I really thank all the 5 presenters that are going to be talking to us today. And then the second hour, we'll have open discussion. It'll be recorded but not uploaded. And the idea is we want free thought within individuals. And then we'll also put together, if you have questions, into the chat so we can make sure if the speakers have that, we can have the speakers and address those questions after the seminar and or after all 5 presentations are done. And then after that time, then, like I said, we'll have open discussion. And the goal of this is to actually try to come up with some type of research questions or protocols or next steps of how we can move this field forward. So with that, we'll go ahead and get into the presenters. So we have 5 presenters today. And again, I really appreciate everybody taking the time on this weekend to do this. The first is John Buttman, who actually participated in the Hearing Science Accelerator since he was in Washington, D.C., where we had that, and actually was our radiology representative at the time. And so John is going to talk about FLAIR imaging to monitor the inner ear. John completed his MD and PhD in neuroscience at the medical science training program at Washington University of Medicine in 1993. He completed his residency also at Washington University at Mallinckrodt and a fellowship in neuroradiology at the University of New Mexico. He received his board certification in diagnostic radiology and certificate of added qualifications in neuroradiology. And so we appreciate him coming here. He was at the NIH for many years. And so, John, thank you for joining us today.
All right, can you hear me?
Yes, sir.
Okay, excellent. Let me move the things. I'm centered in the screen here, more or less. Okay, so yeah, I'm going to talk today a little bit about using FLAIR imaging to monitor ear disease. And one of the, I guess one thing I wish, there's not much published on this, unfortunately, and where it is, it's embedded in things that are sort of invisible to both the radiology and the ENT communities to some degree. Their protocols do not necessarily include FLAIR imaging at all. And I'm leaving out for the moment the whole delayed FLAIR imaging within ear, but in just the routine inner ear imaging, FLAIR is not performed. And as we know from the whole delayed FLAIR imaging literature, FLAIR can be used to detect the leak of contrast. And by doing the delayed imaging, the contrast leaks to an extent that it's detectable, and that allows us to image the membranous labyrinth separate from the endolymph separate from the perilymph. So what I'm talking about is the same phenomenon, but accelerated. If there's inflammation, that leak is facilitated, and so that leak of contrast into the perilymph is detectable immediately following the injection of contrast. And so that is what we're going to talk about. So next slide. Keep going. So this is what we do routinely. We do high resolution water weighted imaging with various arsenal of techniques, and as we know, it's really great for seeing structural abnormalities, but it has provided essentially no information regarding the mechanism of sudden sensorineural hearing loss. Next. And we perform T1 with and without contrast, and really mostly what we're looking for vestibular schwannomas. Occasionally we see inflammatory masses or other mass-like lesions, and very rarely we can see actual presence of enhancement due to inner ear inflammation on the post-contrast T1 sequence, but that was first reported in the 80s, and really, so two possibilities. One is it's not sensitive enough, which is 99% of the problem, and two, maybe in some cases it would have been sensitive enough, but by the time we actually get around to the imaging, that inflammatory pathophysiology has resolved. Next. So this is just to remind everyone of what our hydrographic imaging looks like, where we basically show water versus everything else, and you get exquisite anatomy. Next slide. And just keep going until we hit the next slide. I'm just pointing out various pieces of anatomy familiar to everyone here. And this shows what we see on the T1 post-contrast. There on the right, we see a tiny vestibular schwannoma. Next, and let's go on to next. And here is what we would love to see. Here's a case of labyrinthitis, and on the T1 post-contrast, the cochlea looks normal. And then post-contrast, we see enhancement. So there's clearly something wrong. It's certainly not a destructive mass. It's sort of homogeneously filling both the cochlea and the vestibule here. And, but this is what I'm going to tell you is we can see with a much higher frequency. What that frequency is, I can't tell you. The studies haven't been done. I'm going to show you a few isolated cases, and I showed this to you back in 2023, really not much different, but just to remind everyone what the importance of this phenomenon. So next slide. So here's a case showing you that FLAIR is sensitive where the other sequences are not. And this is actually first case where I identified this phenomenon. So here we have, and this was a combined brain inner ear study on a patient who had sudden sensorineural hearing loss, also had Cogan syndrome. I certainly don't recall what Cogan syndrome is without relying on this slide. That tells me that you have eye disease combined with ear disease, and that's enough for me as a radiologist. But what you can see on the T1 pre-contrast, everything looks normal, and on post-contrast, it looks pretty normal. Could you call a change in enhancement? What we see on the FLAIR post-contrast, there's a striking asymmetry. There is basically a light bulb signal throughout the cochlea and the vestibule. And what I would like you to really, the other point of this was a routine 5mm brain MRI sequence. Now, because I'm sort of been, hounded my techs to make sure they do things symmetrically when it's an inner ear study, so that they had the IACs lined up nicely, and so the brain was lined up nicely as well. And so what you see, the ears symmetrically in both ears, the ears symmetrically on both sides. But this is not a high resolution sequence. It's not a long sequence. This was a routine, 3 to 5 minute post-contrast FLAIR from 20 years ago. Next. And so with the T1, we only really see the inflammatory lesions when they're solid. When they're leaking into water, we don't really see that. And that's a little bit of another discussion, but let's get the next slide. So here with the FLAIR, we see when the contrast leaks into water compartments. So if it's really like the membrane, if the edge, if the stria is inflamed, or the basilar membrane, or these structures at the periphery of the cochlea are inflamed, what that leads to is an excess leak of contrast. And this is what FLAIR post-contrast is designed to detect. Next slide. And here I'm just going to show you a few more cases. This was a case of Wegener's granulomatosis. Here we have the high-resolution T1s on right, and I'm sorry, these arrows are coming up automatically. But you can see, again, on the side with the pathology, the whole labyrinth apparatus is lighting up like a light bulb on the FLAIR. Now, this was a case of mixed disease. And here, to emphasize the T1 showing the solid, this case of Wegener's had an inflammatory mass filling the middle ear cavity, and some of these arrows on the left side of the screen, on the right side of the screen, the left ear, it's shown that that component enhances very briskly on the T1 weighted sequence, but we don't detect that at all on the within the labyrinth itself. So here you could look at the T1 and say, oh, the MR is really great for detecting this inflammatory mass component, and so this just shows the complementary nature of the FLAIR and the T1 as to what it shows effectively. Next slide. And here's a case of a melanoma patient, and who presented, this was actually like 12 years out from his initial diagnosis, and was presenting to an ENT clinic with rapidly progressive sensorineural hearing loss. We did this study. The cochlea lit up bilaterally, but we also see enhancement in the meninges. Here on the T1 post, maybe you see a little enhancement in the internal auditory canals. You can also see, if you go back to the FLAIR, there's a thin line of enhancement along the floor of the fourth ventricle. So he had, in addition to labyrinthitis and meningitis, and following this exam, he had a lumbar puncture, which showed melanoma in his CSF. So, next slide. And this is just showing this is the same case showing you the FLAIR pre-contrast, showing you that there's really absolutely no signal in the inner ear. Also, in contrast to other cases, this is a much higher resolution FLAIR sequence than the previous ones were, because we were really trying to demonstrate this effect in this patient. And let's see, and just show it happens in other phenomena. This is a brain tumor patient who had radiation. And in fact, I see this incidentally really quite often in brain tumor patients, where you see enhancement in either one side, both sides. And you often, for better or worse, it's not the priority in this case, because usually if they've had enough radiation to see this phenomenon, they're not long for the world. Next case. And similarly, it's sensitive to intralabyrinthine hemorrhage. So anything that alters the water content, elevate. Before we were seeing alterations due to leak of contrast. Here, the alterations due to the protein degradation and breakdown products from the hemorrhage itself. And you can see here it is visible on the T1, but it's also very visible on the FLAIR. Next. And next again. And so now I'm going to bring up sort of the poster child case for inflammation of the inner ear here, which is NOMID. You can read what it means. And this is an extremely rare disease, but it's not an autoimmune disease. It's an autoinflammatory disease. So there's basically these poor kids are born with, inflammation. Their whole body is inflamed. They have rash everywhere. They have meningitis. They have labyrinthitis. They have all sorts of joint inflammation. So it's really pretty bad. Hit next. And next. So here the CNS inflammation things are, so the inflammation is on both sides of the blood-brain barrier. So it's, and again, just to recall, this is a auto-inflammatory response. It's mediated through the constitutive upregulation of interleukin-1. And so selective antagonism of that receptor is, targets this disease. The next slide. And so this is just to show you the meningitis. You see the leptomeningitis. So here on the FLAIR post-contrast, you can see the sulci lighting up. And on the T1 post-contrast, we don't see that at all. You may see a little dural enhancement, but we don't see the leak of contrast into the leptomeninges. So I'm showing this because this is the same phenomenon we're seeing in the inner ear. And so there's been much larger literature built up about the use of post-contrast FLAIR for meningitis. And it applies to, even though the literature is not there for the inner ear, it applies in the same way. Next slide. And so here's just an example of that. And again, when we started these cases, we were just doing routine brain MRIs on these patients. But here, without contrast and then post-contrast, the cochlea lights up. Next slide. This slide is just to show that we need the post-contrast FLAIR. We can't rely on the post-contrast T1. Okay, beating a dead horse here. But here is the important point, for going forward is we can use this to monitor the response to therapy. And so so in these patients, when you put them on anakinra, which is an injectable, it does cross the blood-brain barrier, we see resolution of the inner ear enhancement. And so this was important. It showed that we were having an effect, even though we couldn't use, so using the audiometry was not a good way to monitor the disease because, the insult had happened. And really the goal at this point of therapy was to prevent progressive hearing loss. Next. And this is showing a durable response 3 years post-contrast, 3 years post-initiation of therapy. So the next slide. So in this cohort study, we keep bumping through, and let's go back one. So we could use the FLAIR hyperintensity on post-contrast FLAIR as a surrogate marker for having an effect on the cochlea. Next slide. And so here's what I would suggest we do for an acute MRI of the inner ear. It could be very limited. We need the high resolution T2 just to, so see where the anatomy is, make sure nothing else is going on, and do the FLAIR with and without contrast. We don't need ultra high resolution. If we're not looking for high drops, we don't need to do the delayed imaging. So the ultra high resolution is not going to be of any use in the acute phase anyway. Suppose, there may be some issue if there's early enhancement, whether it's confined to the perilymph or whether it's in the endolymph and perilymph, which we weren't able to resolve with the low resolution FLAIR images. And I think that, by doing that, we could do an MR protocol that's less than 15 minutes and would allow us to at least answer a couple of questions. One is, is FLAIR enhancement, is that, if it turns out to be that it's a very rare phenomenon in the acute setting, 5%, then yeah, probably not worth pursuing. But if it's 25% of cases or 20, 50, I have no idea. Even if it's only 10%, maybe it's worth, if you can segregate the the cohort of sudden sensorineural hearing loss to those with early FLAIR enhancement. I'll use the phrase early or immediate FLAIR enhancement to distinguish from delayed enhancement. So immediate FLAIR enhancement in that population of patients, they differ somehow. There's a marker for it. I think we need to find out the incidence and whether it can teach us something. And that's my spiel. Thank you for your attention.
John, that was fantastic. Dr. Buttman, thank you very much. And I'll just remind everybody, if you want to put your questions in the chat, we'll have time to talk about all this. And so that was a great introduction and overview of FLAIR imaging. And I know your thoughts on sudden hearing loss, so it's been wonderful. Our next speaker is Dr. Brian Ward. He earned his medical degree from the University of Pittsburgh, residency training at Johns Hopkins in otolaryngology, and fellowship training in eustachian tube disorders at Boston's Children. But then came back to Johns Hopkins to do neurotology, and he's been there since that time. His research interests are in vestibular physiology and pathophysiology, with particular focus on MRI and its interaction with strong magnetic fields in the inner ear. So, Dr. Ward, Brian, thank you very much for joining us and sharing your research experience. I know you've done a great job with this area, so thank you very much for being a neurotologist talking about imaging. So thank you.
Yeah, it's only mildly intimidating, but thank you for the invitation. All right. Are my slides going to load then, or do I have control over this?
You have control.
Oh, beautiful. Let's see how it works here. Okay. Excellent. All right, so today my goal is to talk a little bit about the limits of what we can see when we're imaging for sudden sensorineural hearing loss, and how different magnetic field strengths, especially at 7 Tesla, can help us see potentially what's invisible. So as we heard earlier, sudden sensorineural hearing loss is often idiopathic. We suspect a range of mechanisms ranging from microvascular, inflammatory, membranous, but we can't see them directly. MRI plays a critical role in ruling out retrocochlear pathology, but subtle inner ear disease may be going undetected. This slide shows kind of where we stand. At the top are conditions that we already see at 3 Tesla MRI, things like schwannoma, endolymphatic hydrops, and rare hemorrhages. The middle row includes findings that we can see on histology, but not yet on imaging, such as ruptures of the membranous labyrinth, eosinophilic precipitates, endolymphatic valve abnormalities. And at the bottom, especially in my world, in the vestibular world, there are all these theoretical disorders which are inferred, things like heavy cupula or canalith jam. And these are still black box entities, which likely have structural correlates, but we just need better imaging to find them. And even in surgery, we find things unexpectedly on occasion. So these are 2 real examples from the vestibular world that underscore our limitations with current imaging. On the left is posterior canal debris in 2 patients who underwent posterior semicircular canal plugging for benign paroxysmal positional vertigo. And on the right is a patient who had labyrinthitis and then developed positional nystagmus that eventually underwent a labyrinthectomy and was found to have a ball of granulation tissue in the ampulla of the horizontal semicircular canal. These weren't invisible. These were invisible, I should say, on preoperative imaging. And so my question is, how many disease processes are we missing simply because we can't see them yet? Part of the problem is scale. So the inner ear is smaller than your pinky nail. And the inner ear membranes are even smaller than that, sub-millimeter in size. So clearly imaging these structures demands extraordinary spatial resolution, and that's where field strength starts to matter. MRI signal increases with magnetic field strength, and that's why 3 Tesla is the standard for otologic imaging of the inner ear. It gives you double the signal of 1.5 Tesla, and 7 Tesla gives you more than double that again. With that extra signal, you can shrink the voxel size without losing image quality. Although still mostly limited to research centers, ultra-high field scanners such as 7 Tesla is growing in access. So there are over 130 of these worldwide, and there's more than 50 in North America. And that means what we learn in research settings may soon be scalable. But resolution isn't just about detail, it's about accuracy. And partial volume averaging means that small structures get smeared across voxels, blurring the anatomy. So at 3 Tesla, we sometimes are seeing averages and not edges. And partial volume averaging is one of the most important limitations, I think, in MRI of the inner ear. The labyrinth is really small, as I showed. And when voxels are too big, multiple tissue types end up getting blurred. So on the left, even at 3 Tesla, you can start to see these dark areas within the vestibule. And on the center, this shows histology anatomy of what's truly there. What I'm trying to demonstrate here is that if you take the histology and cut it into a series of slices, if you look at this voxel here, it represents both fluid and soft tissue structure. But the 3-dimensional voxel ends up being reduced to a single 2-dimensional pixel on your screen. And so that's how you get this sort of blurring. The smaller the voxel size, the closer you get to ground truth. This slide shows what that means in a little bit more detail. So the left column is a grayscale of the histology. And in the next 2 columns, that represents what I did to downsample the image. And you can see how the anatomy starts to kind of blur as you downsample the image. So partial volume averaging isn't just a technical concept, it directly limits what we can diagnose. If you think about trying to identify something like a small membrane rupture or otoconal debris, averaging can completely erase the signal. So you might have the right pulse sequence, the right patient, but the voxel size is just too big. As the spatial resolution gets closer to histology, walls of the membranous labyrinth, the cochlear partition, and other pathologic processes can begin to become visible. So does 7 Tesla help? Yes, but only with the right techniques. And so one of the other problems with higher field strengths is there are more magnetic field inhomogeneities. And so we first started imaging patients because the temporal bone is a mix of different signal or different kinds of tissues, you get a lot of signal drop off around the temporal bone. And so at the beginning, you couldn't see the inner ear at all. Using dielectric pads and B1 field shimming, we can now consistently see the inner ears in subjects when we image them. On the left, you can see the spatial resolution difference. This was done in 2015 between 3T and 7T. And you begin to reveal structures like the singular nerve and improved fine detail within the cochlea, things that were previously indistinct. So this is where we are today. This is what we do at Kennedy Krieger and at Hopkins. So these are what you're seeing on the left is a non-contrast 7T image of a healthy adult. And we can often see in this coronal section, commonly the walls of the membranous labyrinth start to become visible, as does the utricular macula. On the right is a post-contrast scan, as well as the T2 and coronal. And this is a very small vestibular schwannoma, but it was helpful for us because we could see it coming from the superior vestibular nerve, and that ultimately guided us toward a hearing preservation middle fossa approach. We also use the delayed contrast imaging in Meniere's disease, which you're going to hear more about in coming lecture talks. So here we segmented structures like the cochlear duct, the saccule, the semicircular canal. We can now do what we do at 3 Tesla, but with better spatial resolution, better contrast, and we can start to generate 3D reconstructions of the inner ear. So in this 3D reconstruction on the right, each of those cubes is the voxel that we see at 7 Tesla. It's roughly 4 times smaller than what you can achieve at 3 Tesla. And we're beginning to use this to compare disease states such as Meniere's disease to look at what parts of the inner ear might be hydropic in Meniere's disease. Even higher magnetic fields, things like 11.7 Tesla, are already resolving structures like the cupula and the crista. So these are from a temporal bone and an animal model. And I show this zero echo time image just to kind of emphasize, especially when we're thinking about preoperative cochlear implant scans, often it's helpful potentially in kids to have an MRI and a CT scan. So you may be able to achieve some CT-like resolution with zero echo time imaging. And then with time of flight at 7 Tesla, it's already been demonstrated that you can see labyrinthine artery and spiral medullary artery. We could identify things like a dysmorphic ampulla or vascular compression syndromes, which might avoid exploratory surgery in some of the earlier examples I talked about. Functionally, we're also seeing progress too. So Diffusion tensor imaging and tractography can identify things like the facial nerve. We might be able to use this to look at the vestibulocochlear nerve in sudden sensorineural hearing loss. As you get to higher field strengths, we can start to explore non-protons, things like sodium, potassium imaging. There's a lot to work out to get there, but you might be able to visualize ionic gradients. And flow imaging might eventually allow us to see fluid movement within the inner ear. This is something that our group is particularly interested in because of these Lorentz forces that we think are happening inside the labyrinth at 3 Tesla and higher magnetic fields. So here's the takeaway. Field strength matters. It opens new anatomic visibility. But even at 7 Tesla, many sudden sensorineural hearing loss mechanisms may remain invisible. To move forward, we need finer spatial resolution, less partial volume averaging, and new contrast techniques to reveal diseases that we suspect but still can't see. This isn't just about making prettier images. It's about answering clinical questions. I think it's incredibly frustrating that we cannot see the problem in the vast majority of the patients that we interact with. And I think that's one of the promises of this technology. So I do want to thank my collaborators. This is not done in isolation, particularly Jun Hua, who MRI physicist at Kennedy Krieger I work with, and Francis Deng, who's a radiologist at Johns Hopkins. And of course, I can't do this without my funding agencies, so special thanks to them as well. And thank you for your time and attention.
Brian, thank you very much. That was wonderful overview. And again, appreciate the chat questions that are coming in. That's going to be helpful going forward. Our next speaker is another neuro-otologist, Kira Ishiyama, who received his medical degree from Northwestern University, did his internship and head and neck residency at UCLA, stayed at UCLA and is a full professor there. He's involved in research in Meniere's disease and is also the director of the temporal bone lab at UCLA, working on better understanding of pathophysiology of Meniere's disease. And Kira has done quite a bit of work also on looking at delayed imaging protocols of the inner ear. So Dr. Ishiyama, thank you for joining us.
Thank you, Bill, for the kind introduction. Do I have to control the slides?
Yes, you could control them.
It doesn't seem to advance. Oh, here we go. So it's been already discussed when you do a delayed MRI contrast infusion systemically, the contrast diffuses preferentially into the perilymphatic space. So here in this diagram, the blue is the perilymph containing space, and endolymph containing space doesn't receive the contrast, and therefore you can create the contrast differential. So when you have, for example, as indicated in B, endolymphatic heart drops, the endolymphatic space expands and the perilymphatic space gets smaller, and you can see that. And has been already discussed, by doing a high resolution 3D FLAIR, you can consistently differentiate endolymph from perilymphatic containing space that you can see on the right-hand side. And we have been applying this subtraction image along with the FLAIR over the last 15 years, and we've been using this MRI imaging protocol, and it's been extremely helpful. You can actually look at the presence of endolymphatic heart drops at the cochlear duct, saccule, and uticle, so you can actually describe regional changes utilizing this modality. So this is again the demonstration of how we can see the regional changes applying this technology. So we have actually investigated isolated cochlear heart drops, and it appears that this is a discrete entity, and we have been following these patients for over 15 years in some of the cases, and the only symptom they develop is the cochlear symptoms, but they don't get any vestibular symptoms. So this is another case of FLAIR image, subtracted image, and cysternographic images. And this is the case series we published on isolated cochlear eye drops cases. On the other hand, you can actually see isolated circular changes, as you see over here. This is a very interesting entity in our opinion, because in many cases, Meniere's disease appears to start in the area of the saccule. And these patients, although radiologically you can have isolated circular eye drops, clinically it behaves as a full-blown Meniere's disease, including hearing fluctuation, low frequency hearing loss, rotational vertigo that lasts more than 20 minutes. So when we analyze the isolated circular cases, in all the cases, patient with circular eye drops had vestibular symptoms, and nearly all of the patient had a past or present history of recurrent spells of spontaneous rotational vertigo. And some of those patients actually had a non-specific dizziness, such as rocking sensation, off balance sensation. In these cases, we found the use of imaging study to be extremely helpful. We also had a group of patients who responded extremely well to the use of a diuretic, although this was a small group of patients. For example, in A, you don't see the in A, you don't see the perilymph signal demonstrating presence of endolymphatic eye drops. When we gave Diamox, rather immediately, usually within 24 hours, patient report significant improvement in the hearing. And then when we did the imaging study, you can actually see the resolution of eye drops. And then when you stop the treatment, the eye drops return. So in some of the cases, it appears to be a dynamic process, and you can actually visualize it utilizing the MRI. So this was a case where a patient actually had a schwannoma, and you can see the presence of endolymphatic eye drops. So in this presence of eye drops, it's not that uncommon when you have schwannoma, but you can utilize this imaging modality to visualize it. Now, what's interesting is 2012, Yamazaki published a paper looking at the FLAIR signal change. So as you see on the right, this is a extremely, bright signal. On the left side is much less. And this appears to be, in many cases, the first changes we see when a patient gets Meniere's disease. So we looked at the, in 2016, looked at the FLAIR change in the symptomatic Meniere's disease and asymptomatic contralateral ear in terms of the FLAIR signal. And it was clear that even in the asymptomatic ear, where patient didn't have any clinical symptom, if you have a symptomatic disease in the other ear, you can have a significant increase in the FLAIR signal. We also looked at the sudden hearing loss patients, and we didn't really see much elevation of FLAIR signal. So it appears to be a very different entity. So in order to understand what this means physiologically, we actually looked at the histology slides from surgical specimens, because there is a entity has been shown before, similar to the blood-brain barrier. Inner ear has a similar structure called the blood labyrinthine barrier. So we wanted to see whether the abnormality of the blood labyrinthine barrier might be involved to explain the changes we observed on MRI. And indeed, A is the autopsy control, and B and C, C basically shows a significant amount of edema in the stroma, vasculatures are dilated, and the basement membrane is significantly thickened. So when we actually looked at the changes under the electron microscopy, there is a significant derangement of the microvasculature where you have a thickening of the perivascular membrane, and you can actually see detachment of the pericytes from the capillary wall, and the vascular endothelium within the interluminal space has significant changes. So this is the summary of the changes that we have detected: the thickening of the perivascular basement membrane, and you can see a significant increase in the vesicles within the vascular endothelium, and the pericytes appear to have significant degenerative changes. And this is the summary again of the microvascular changes that we observed. What's interesting is when you actually interview a patient with a Meniere disease, many of the patients appear to have symptoms compatible with excitation of a sympathetic nervous system, as described here. So collaborating with a very productive group in Tokyo, Japan, because they have a very extensive subway system. When a patient has Meniere's disease, they can hop onto the subway and get to the clinic. And what was done was to do a measurement called electronic pupillometry to look at the response of the pupils, measuring the effect of a sympathetic nervous system and the parasympathetic nervous system. So as the stimulus is presented, initially you have a pupillary constriction, which signifies the involvement of the parasympathetic system, and there's a recovery phase, which is the pupillary dilation, which is the sympathetic nervous system. So we actually took a measurement from close to 600 patients, and there were 8 patients who actually had the Meniere's attack right around the time that the measurements were taken. And this is a diagram summarizing the pupillometer changes. And interestingly, right before the attack, and there is a significant decrease in the parasympathetic tone, but the sudden rise in the sympathetic tone, although the contralateral side doesn't demonstrate it. And as the attack goes away, the reverse happens. So this appears to be a physiologic demonstration of unilateral sympathetic hyperactivation followed by parasympathetic takeover during the recovery phase. So to conclude, high resolution MRI in our experience appears to be extremely helpful to work up patients with audiovisual dysfunction. And using the 3D protocol we have, it demonstrates regional changes within the inner ear. And Meniere's disease clears to have very close association with abnormality of the blood-labyrinthine barrier. And by pushing for the information we obtain from MRI, we might be able to better understand the underlying physiology. And I find the imaging study to be extremely useful. Thank you very much for your attention.
Akira, Dr. Ishiyama, thank you very much for the wonderful overview of delayed imaging. That was very nice. So again, I appreciate everybody going to the chat to put their questions in there. So our next speaker is Dr. John Go, who did his undergraduate studies at Washington University in St. Louis, went to medical school at the University of Tennessee in Memphis, residency at Mount Sinai in New York, and the neuroradiology fellowship at USC. He stayed at USC for over 25 years and recently is serving as the director of head and neck radiology at UCLA. So John, thank you for coming and giving us a talk.
Thank you for the invite. I have no disclosures. So, in imaging endolymphatic hydrops, obviously, when we talk about the inner ear, obviously there's the bony labyrinth, which houses the membranous labyrinth. And so, contained with the cochlea is a cochlear duct within the vespers utrocolsaceal of the membranous labyrinth, and within the semicircular canals are the semicircular ducts. And together, that's basically the inner ear. And so, when you do high resolution T2-weighted images, you can't separate the membranous labyrinth from the osseous labyrinth. So, and these high resolution T2 weighted images, whether it's thin section, whether this is a KISS sequence on Siemens or a Fiesta C on GE or phase imaging on a Canon system, these high resolution T2 weighted images really don't help us distinguish between the membranous and the membranous labyrinth versus the from the bony labyrinth. So was mentioned by a number of the speakers with regards to doing contrast enhanced MRI to actually visualize the membranous labyrinth. There are a number of different ways in which you can actually do this. And so my talk is sort of basically methodology. In the past, what you could do is you could do intratympanic injections of gadolinium as a double dose and do 24-hour delayed imaging of the inner ear with FLAIR images. And the principle, basically, as Dr. Ishiyama mentioned in his talk, is that there's delayed excretion of contrast preferentially into the perilymph, and so we are able to secondarily image the endolymph because of the contrast enhancement within the perilymph. And there are a number of ways that you can actually do this. When I was at USC, the subtraction imaging technique that Dr. Ishiyama mentioned, which I'm currently at UCLA now and currently use, and I do like that. We didn't have that capability of doing that, but we used the principle of 3D FLAIR imaging. And Dr. Putnam had initially talked about FLAIR imaging, but that was actually in the acute setting, because when you do 4-hour delayed images, you could see the excretion of the contrast into the perilymph. And because CSF is nulled and the inner ear, the osseous labyrinth with both the endolymph and perilymph is fluid, the fluid is actually nulled. And so when you have delayed contrast excretion into the perilymph, then you can secondarily see the endolymph. And so this is a sequence that's available on pretty much all scanners at this point, a 3D FLAIR sequence. It's also called fast FLAIR cube imaging. It's isotropic imaging. And if you're not capable, you don't have the capabilities of do subtraction imaging, this is a way that you could actually image the perilymph by doing 4-hour delayed 3D cube FLAIR imaging with the thinnest slices possible. We were scanning under 1 millimeter in terms of slice thickness, and the voxels were isotropic. And then what you could do is you could invert the images to visualize the endolymph itself. The current technique that we actually use here at UCLA is a modified FLAIR sequence, in which we use two different inversion times at 2,350 milliseconds and 2,050 milliseconds, and we subtract one from the other, the base image, to subtract out all the tissue so that we can actually see the membranous labyrinth. So let me show you some examples. And here's an example of, this is with 3D FLAIR cube imaging. And so there is no subtraction involved. And one of the things when you do subtraction imaging is that if the patient moves between the two sequence acquisitions, then that's going to corrupt the images, and you won't have a diagnostic image. At least one of the beauties of doing just 3D FLAIR images with image reversal is that there is no subtraction here. So, but when you invert the image, you can see the membranous labyrinth, the utricle, and the saccule within the vestibule as filling defects, and you would see filling defects if there's dilatation of the membranous labyrinth here, as for example, in this case, in this patient with Meniere's disease on the left, and you can see that the utricle, which is posterior superior, the saccule anterior anterior and inferior, basically has effaced the vestibule. So the perilymph, the contrast itself, is basically pushed because of distension of the membranous labyrinth. And you can also see dilatation of the cochlear duct. So this is an example, again, using 3D FLAIR cube imaging with image reversal, no subtraction involved. Now, in the subtraction method, this is a modified FLAIR sequence. So the CSF is not nulled here because this is not the inversion time for CSF. It's actually the specified time, as I mentioned, 2,350 milliseconds and 2050. So when you look at these base images, you don't really see much here, right? But if you were to subtract and do a subtraction method, this is what you basically get. So in this video, I'm just scrolling through the data set. You can see that the membranous labyrinth is going to be black in the background of the subtracted perilymph here. And so you can actually see it pretty well, but this will only become valid if the patient really does not move. So, and just going to scroll through this data set again. So you can see like right side, left side, you can see within the, and you can see the cochlear duct. You can also see the utricle and saccule membranous labyrinth. So the next question is going to be, well, when do you call Meniere's disease? And so that's actually right for research basically to determine that, because I don't think there's really normative data for that. So what I've seen in literature has been, okay, it's considered abnormal if it takes up 30% of the volume, and if it's actually at 50%, that's significant. Significant for endolymphatic hydrops. And for the cochlear duct within the cochlea itself, if you were to take within the turns, if within each medial and lateral aspect of the turn on an axial image, if it takes up more than 50% of the volume, the cochlear duct takes up more than 50% of the volume with that apical turn, then that would be considered positive. Let me see. I think it was. So this was that case with the hydrops. We can see the on this subtracted image, the distension of the utricle and saccule here. In this example, and it's going to play through. You can see cochlear duct dilatation here on the right side. You can see the effacement that the utricle and saccule is distended and takes up more than 50% of the volume of the vestibule on the right side here. So, so this is an example of Meniere's disease on the right side. And then for this case, in case number 3, here you can see the distension of the utricle and saccule within the vestibule, as well as distension of the cochlear duct on these subtracted images. So this is a nice or robust way of looking at the membranous labyrinth with subtraction imaging. Again, but a lot of institutions don't have this capability of doing subtraction. So I think the next best thing is to do the 3D FLAIR imaging with 3D FLAIR cube imaging. And again, that's on most magnets at this point at 1.5 and 3T. And just invert the image after FAR delayed. With that, I think some of the questions that were asked by Dr. Slattery with regards to can this be incorporated into a temporal bone protocol, because of the it's because of the delayed imaging that becomes a problem because of the number of MRs that are being ordered. If you have to scan the patient for anatomical imaging first and then have to wait 4 hours to bring them back, that's scanner time that could be problematic. But this application of FLAIR is a little different from Dr. Putnam's, because Dr. Putnam's examples were all in the acute setting, as opposed to the FAR delayed imaging. With that, thank you.
Thank you, John. Wonderful overview, some beautiful pictures. Things for us to discuss. So really appreciate it. We'll continue that discussion in a few minutes. But first, we have Dr. Amy Giuliano, who's a neuroradiologist specializing in head and neck radiology in the Department of Radiology at Mass Pioneer at Harvard Medical School. She did her medical school training at the University of Pennsylvania, residency at Brigham and Women's Hospital, and then neuroradiology at Brigham and Williams Hospital. And her research interest includes temporal bone imaging and correlation of anatomy and physiology. So Amy, thank you, Dr. Giuliano, for visiting us today and giving us this presentation. Thank you.
Thank you so much, Dr. Slattery, and it's great to be here in such great company. So I'll share my screen and I will talk a bit about timing of MRI with onset of sudden sensorineural hearing loss. And there is some overlap with the earlier talks, but I think that's great just to see, repeated ideas and what we might think and about them and do in the future. So I will talk a bit about causes of sudden sensorineural hearing loss, MR protocol to consider, what some papers there are in the literature and examples that we may see. So in terms of sudden sensorineural hearing loss, we can think about etiologies, the relevant anatomy, what parts of the neurological system could be abnormal, and the way we look at them by imaging. So there's a whole host of etiologies with hearing loss. It could be central in the brain, brainstem nuclei, all the way to peripherally in the end organ itself, in the inner ear. So we think about ischemia, neurologic diseases. There can be hemorrhage, and I've seen a couple of cases of sudden hemorrhage into the cochlea. There can be infection, inflammatory processes in the ear itself or going centrally along the nerve. Demyelinating process, Meniere, we talked about, from ototoxic medication, autoimmune, metabolic, systemic, and then schwannoma. And I would say that traditionally in the past decades, the reason seems to me when I see referrals for MRI coming in, when MRIs get ordered, it's really to rule out. It's to say, okay, I see this patient, they have sensorineural hearing loss, it's sudden, and let me just make sure it's not because of a schwannoma. So our job was just basically to see if there's a tumor. And with that, in terms of the timing of imaging, I suppose it doesn't matter so much. The tumor's been sitting there, maybe there's been all of a sudden the nerve is more compromised and suddenly the symptoms become manifest. But you can do it today, you can do it next week, and do it next month, it doesn't really matter. And the false negative is probably pretty low because we'll see it. But when we move into the era of imaging, as everybody has been talking about now, it's to catch, do we see anything that might be inflammatory? That's a little different. And we may need to now chase it down early. With Meniere, that's another consideration where, with high drops, it's probably been that way for a while, depending on what we think about the reason patients have high drops. What type of an epiphenomenon it may be. We may have ideas about when to image, but again, that's probably not so acute. So to rule out problems like a schwannoma, to see if it's Meniere, it's not a big rush. But if we want to look into ischemia, hemorrhage, inflammation, we probably want to do it soon. What's the relevant anatomy? Well, it's going to be, we want to look at the labyrinth itself. And there's discussion about whether the end result really is a microvascular injury to the cochlear blood supply. Then there's the nerve connecting the ear to the brain. So, the eighth nerve, and then the brain and brainstem. And if we're talking about sensorineural hearing loss, it's really in the domain of MRI. And especially if it's sudden, we're not talking about cochlear anomaly, like you're born with an IP2, you're born with an IP1, or, charge syndrome or something like that. We're talking about non-structural, and we're talking about tissue and fluid. So it's really in the domain of MRI. And MRI is helpful, especially if steroids have been started and it's not really helping, if it's asymmetric. But I would say even if it's symmetric, if it's a systemic disease, metabolic disease, because now we're not talking about ruling out tumors necessarily. So I think things to think about is, when will imaging be positive? That would guide our referring and ordering habits. But also, could it be a false negative? So we have to do the imaging properly, correctly, and judiciously. So in terms of a protocol, this is the type of 3D FLAIR that people have been talking about probably in, 10 years ago, 20 years ago. This is a type of 3D FLAIR we do for the brain. And it's very important to note that this is not the type of 3D FLAIR that everyone has been talking about, and that's really the talk of the town these days with Meniere. FLAIR stands for Fluid Attenuation Inversion Recovery, which means there's an inversion pulse applied, and the inversion time is timed so that it suppresses fluid signal at a particular time, millisecond, which means there's a type of fluid we're looking at. So the traditional FLAIR imaging for brain, we time the inversion pulse so that the CSF signal is gone. So this is specific to making CSF signal be nulled out. So this is what this FLAIR is. And in fact, this patient just came through. I just read this scan last week. It was a 20-some-year-old with hearing problems that eventually didn't go away, had nausea, had dizziness. And already here, this MRI was ordered 2 weeks after the initial presentation. And we can see on this FLAIR of the brain, not the type of FLAIR from Meniere, we see bright signal in the left labyrinthine structures here. And so this means it's not fluid signal that's similar to CSF or similar to, on the right side, perilymph, endolymph, but it's proteinaceous. So this kind of also does tell you that something is wrong on the left side. So this is the type of 3D FLAIR for the brain. We always do a T2 because, we want to see what's happening with the brain itself, the brainstem. But in terms of the fluid signal in the inner ear, it's not so very helpful. These are thicker slices. They're 3 millimeters, sometimes even 4, if we want to do a quick T2 protocol. Here it looks, maybe you can say, is a little darker, but it's hard to tell. But really, it's done for the brain as a big picture. Is there something wrong with the brainstem, with the brain? And then, of course, that has been mentioned before, we do a heavily T2 weighted sequence, which means CSF and things that are similar to CSF, very, very, very bright, and everything else is super dark. And depending on the vendor, this is the Fiesta or the Drive or the KISS or what have you. But the theory, it's a heavily T2 weighted sequence. And of course, this doesn't really separate endolymph, and perilymph at all. But it's really to make sure that we're seeing CSF, there's not a vestibular schwannoma, there's not an anomaly, there's not, let's say, a cochlear schwannoma sitting in there. And that's in fact a pitfall. When we read a Meniere endolymph space, that's a cochlear hydrops or that's a saccular hydrops. But once we do this heavily T2 weighted sequence, we might actually see that it's not fluid at all. It's not endolymph, but it's a space occupying mass and it's a schwannoma, an intralabyrinthine schwannoma. So we need this sequence all the time to help us diagnose things that this sequence is capable of, like a vestibular schwannoma, but also as an adjunct when we interpret the Meniere sequences to make sure it really is a big endolymph that's dilated and not an intralabyrinthine schwannoma, for example. Of course, we do the usual T1 weighted sequence, spin echo, pre-post contrast, and here we can see a bit of enhancement in this patient, but not, super distinct, a bit in the, you can even see scala tympani, a bit in the IAC. And then, of course, we want the pre-contrast to make sure it really is enhancement and not an intrinsic bright signal, as you might see with a hemorrhage. So things are all necessary here. And this patient actually turned out to have vesicle eruption later in the ear, and this was a zoster oticus or Ramsay Hunt. Then it has been mentioned that there's a 4-hour delayed 3D FLAIR we do now, a lot of times in the setting of Meniere. But it's really important to note that that is a different inversion time. So John, I think, mentioned a little bit before about the 2 inversion times they do, and it's to null out perilymph and null out endolymph. And you can choose to do what you need, but the typical 4-hour delayed 3D FLAIR for Meniere imaging is to null out endolymph. So the inversion time is different for this as opposed to the one for the usual CSF nulling that's traditionally done for brain imaging. So different inversion times. So at Meniere, this is our usual protocol for sensorineural hearing loss. It looks very busy, but it boils down to, in the whole brain, we do a diffusion, make sure there's no infarct. We do a susceptibility because you can get a sensorineural hearing loss from a bleed, a subarachnoid bleed. You can have superficial siderosis. So we do the susceptibility weighted sequence, in the past it's GRE, a gradient, to make sure there's not actually old blood that's coating all the cerebellar folia and the nerves, and that's the reason for sensorineural hearing loss. We do the usual T2 to look at a big picture of the whole brain. And then we do the 3D FLAIR, that's the traditional one, and the inversion time is for CSF nulling. We do a post-GAD, high-res, 3Ds, SPGR, again, to look at the brain. And then we do those inner ear sequences, the heavily T2 weighted sequence, super thin, and we do a T1 pre and post. And then the question is, do we add this heavily, this 3D FLAIR that's done for Meniere imaging where we null out endolymph signal? And this can be done a couple different ways. So the Japanese group, Naganawa, from back in the beginning, they have a different TETR. From later on, the Europeans, they have a shorter TR, and it makes the brain a little bit less dark, but the theory is about similar. And now, of course, there's the 3D real IR, where it's a different type of nulling and inversion time. And then the difference also is when you do this 3D FLAIR imaging that nulls out endolymph. Do you do it right away, like a 10-minute delay, or the 4-hour delay, like for Meniere? And I'll show you papers about that. Of course, everybody talks about AI. In radiology, it's a big deal to talk about AI. And now there are methods about how we can accentuate signal and diminish noise by doing synthetic MR sequences. So that's a possibility. I just learned last week at our big national neuroradiology meeting that there's software now where you can accentuate contrast enhancement. So you can say, you know, I'm going to use, you know, double dose, single dose, the new high relaxivity ones. But you can also use AI now, apparently, to accentuate contrast. So even if the dose is single, or maybe even half dose, it can look really bright, and it's a function of AI. So how do we navigate this new domain? Do we trust it? How do we make sure AI is not falsely accentuating it and it doesn't represent real pathology? It's a lot of things to think about. Meniere, we've already talked about. Saccular eye drops generally matches symptoms, and then the degree of enhancement is really breakdown of the blood labyrinth barrier, not specific to Meniere per se, but has to do with sensorineural hearing loss. So in terms of timing, I think we need to image when the pathology is there, because otherwise it's for ruling out. And so if empiric therapy is very important clinically, where patients get steroids right away to help recovery chances be higher, then if steroids has started already and then you image by MR, well, have you taken away what we might have been able to see from a fresh slate? And now steroid has already worked its way to help ameliorate the original pathology, and we cannot tell so much on MR anymore. Could it generate a false negative? Can we now not find the cause, even though maybe originally it was potentially possible? And what we see now may not be the initial problem. It may have effects from the steroids. So there's a lot to think about when we start doing MR at a time point when therapy has already started. So this is back in 1998. Castleman was in Belgium at the time. Now he's in Canada. But, authority in head and neck imaging, and even back in 1998, to improve the sensitivity of MR imaging in idiopathic sudden sensorineural hearing loss, they recommend imaging be performed as early as possible, preferably before treatment is started. A paper in 2015 comparing inner ear contrast enhancement, 10-minute delay from 4-hour delay. And this is the Meniere type 3D FLAIR. And they found that with non-neuritis related pathologies, the 10-minute delay seems to be more effective. But when it has to do with neuritis, the 4-hour delay tends to be higher sensitivity. And that was what they mentioned. And I think it's so important in all research studies and all papers for people really to go into the specifics about imaging protocols and parameters, because it can be vastly different depending on the vendor, which company MRI scanner it is. What's the TE? What's the TR? What's the TI? You want it to be reproducible. You want it to be obvious so that research done can be comparing apples to apples. So here they did list their parameters so you can be clear and know, which TTR, although they did not actually list the inversion time on this paper. Another paper a year later, 2016, mentioning the prognostic value of these 3D FLAIR abnormalities. And they found that these 3D FLAIR MR abnormalities were found in 27% of patients with sudden sensorineural hearing loss. And if there are findings at MRI positive, the initial hearing loss was worse than those with negative MRI. But one thing about this is they never mentioned the timing of MRI in relation to a steroid initiation. But they did talk about steroids relative to performance of audiogram. They did list parameters for the 3D FLAIR. So they talked about the slice thickness, the TETR, and the inversion time. So we know this is the type done for endolymph suppression. Another paper, and this is a review paper out of Europe. And they mentioned, it's time to talk. And they say that in their opinion, optimal timing would be upon admission to the ER or same day as clinical assessment, and that any abnormality would be more easily detected before steroid treatment has started. So MR imaging really should be performed as soon as possible before masking effects of steroids become apparent. So in summary, I think it's very important we do the correct and appropriate MR sequences and know the limitations of each and also the strengths of each. Ideally, we do it as soon as possible and before the onset of treatment. And I think in the domain of research and for the future, it's so important that we, in radiology papers, to always have the physics components apparent, that we list the sequences, that we know that we're comparing apples to apples, that we can build upon preceding research, doing the right thing, and that we're comparing the right parameters. And with that, that's the end of my presentation. Thank you.
Wonderful. Dr. Juliana, thank you for your talk. Very nice bringing us up to date on literature, but also some nice talks about timing. So maybe what we can work on is looking at some different protocols that would be helpful, and we'll do some circulation with the different groups and have people comment and come up with maybe three, like I said, 3 different protocols that we could see how we could then circulate that to different individuals, and hopefully, again, the idea is if we have these protocols put together, maybe we could have see who'd be interested in starting doing some of these techniques clinically and applying them clinically, and then working together to get a group of patients. And I would think you'd probably want to have somewhere 20, 30 patients that look at each protocol, see what kind of benefit we get, and maybe look at how we change those over time. So with that, again, really appreciate everybody joining us today. On this Memorial Day weekend in the United States. We've had people from Europe and also South America and maybe other places here as well. So again, to the speakers, great job. Thank you for taking the time. And if anybody has questions going forward, the seminar was recorded. The discussion will not be uploaded, but we will have the questions or summary of the comments at the end. And then we'll get a written summary to everybody as well. And if you have further comments or questions, email myself or Shems, and we'll get back with you. But again, we appreciate y'all taking the time. So thank you very much.